Welcome to session 41 of the Falcon Physician Review series online. This time we'll be discussing the trigeminal nerve. The trigeminal nerve will be a definite recurring theme throughout the questions associated with head and neck. So it's an important nerve to get a clear grip of. Let's start with the question as we get going. A 23-year-old female victim of a mugging has been brought to the emergency department and the following image was taken. She complains of numbness of her teeth and lingual gums. What is the most likely nerve that's been damaged? The answer is infraorbital nerve. The infraorbital nerve travels through the maxillary sinus, and you can see that the maxilla and the zygoma have been fractured open and there's bleeding into that maxillary sinus. This can actually sever some of the branches coming from the infraorbital nerve, which will be going in and contributing to the superior dental plexus of nerves. So I'm sure she would have numbness of some of her upper teeth, just like she'd been to a dentist. Now, as we look at the face here, some of the clinical features of the face will be those skin tension lines. And the regional skin tension lines, are also known as Langer lines, are going to be important because those wrinkles will be tangential to the pull direction of the facial muscles that are underlying them. And if you're going to do any cutting or removal of structures on the face, then you'll want to cut across those Langer lines and bring them back into the plane that they're supposed to be working on. Otherwise, there can be bad scarring. Also, in addition, you want to know what the underlying features of this structures are so that you don't damage any nerves laying across there. For instance, if you're trying to suture someone up, what nerves are at risk in this operation? Now, let's look at all the branches that distribute onto the face. The sensory branches distributing to the face are going to be branches of the trigeminal. And you can see here that there's about 56 branches, not all of which are coming superficially, but don't worry, we're only going to review about 55 of them. That would be horrible. I won't do that to you. Now, if we look at the distribution in general in green, blue, and red, you can see that there'll be V1, V2, and V3 distribution patterns. Above the corner of the eye and onto the bridge of the nose is V1. Below the corner of the eye and above the corner of the mouth is a V2 distribution pattern. And below the corner of the mouth, sweeping up in front of the ear, is the V3 distribution pattern. Notice how the back of the head is innervated by C2 and C3. Notice also that there is no C1 distribution of sensation to the skull, in that the C1 nerve is entirely motor and goes into the ansa cervicalis. Let's look at the divisions of the trigeminal nerve. You may remember that the trigeminal nerve is holding its sensory cell bodies, the pseudounipolar, which would be the equivalent of a dorsal root ganglia, except for this is a cranial nerve associated one, and it's going to be in the cranial vault right near the cavernous sinus. Then there's going to be three divisions of this trigeminal sensory nerve: the ophthalmic, which will distribute to the orbit; the maxillary, which distributes to the midface, and those two are only general sensation. But the trigeminal nerve in general is going to be both motor and sensory, and it's that third portion, the mandibular nerve, that carries motor to the muscles of mastication and sensation below the corner of the mouth up towards the temple. Here you can see distribution of the herpes zoster or shingles virus, which is going to be retroactive chickenpox infection that occurs during adulthood. Typically, it's starting to occur over the age of 50 in 2/3 of those cases. And then what you can see is that this is in a V1 distribution pattern. Here we have a V2 distribution pattern of shingles, and in this person you have a V3 distribution pattern of shingles. The areas of the eye that can be infected during a V1 distribution pattern can actually affect the cornea, and that can cause zoster keratitis. And if zoster keratitis is not treated properly, it can scar the cornea, and this is one effect of herpes zosters that can lead to blindness. Here we can see some distributions from the foramina of V1, V2, and V3. Notice how they come out of the supraorbital, infraorbital, and mental foramen in a vertical plane. And you can basically line these up by feeling the notch of the supraorbital notch and then lining it up with the corner of the mouth as you drop a vertical line down, and you can see the distribution pattern of the supraorbital, infraorbital, and mental nerves. This is a dissection I did of the trigeminal ganglia and the cavernous sinus, and you can see the trigeminal ganglia as it distributes V1 through the superior orbital fissure, V2 through foramen rotundum, and V3 through foramen ovale. This is going to be an important structure because this can be affected in the tic douloureux or the trigeminal neuralgia, which can be very painful. And the suicide rate for people that have tic douloureux with the intractable version is about 5 times that among above normal populations. The intermittent kind can sometimes go away, but the constant one is a piercing, burning, fiery pain that will oftentimes drive people almost insane. They can be ablated to treat this, though, and there's going to be endoscopic methods of following these branches of the trigeminal nerve back towards the ganglia, where it can be ablated either using chemical or radioablation or surgical ablation or even chemical radiation. The cavernous sinus thrombus, the CTS, is also going to be a problem and can be caused from infections in the central face or even in the paranasal sinuses. They're often caused by bacteremia, trauma, and infection of the ear or the teeth. There's fairly high rates of morbidity associated with a cavernous sinus thrombus because of the cranial nerve effects. Antibiotics have reduced this. However, there's often a good sign that goes with the cavernous sinus thrombus in that you have a severe headache because it pushes on the dura, and then you'll have fevers, periorbital edema, and cranial nerve signs, especially those cranial nerves that run through the cavernous sinus. The parasympathetic ganglia that we already looked at for the ciliary, pterygopalatine, otic, and submandibular are actually distributing with V1, V2, and V3. Notice how there are 2 that distribute with V3. So we've looked at the trends in the parasympathetics, and we've now seen where they will all go, where the cranial nerve 3 will be distributing to the ciliary ganglia. That will distribute on V1 branches of the trigeminal and distribute above the corner of the eye. The cranial nerve 7 has the pterygopalatine and submandibular ganglia, which will distribute from V2 and V3 respectively, which will innervate all of the glands that are between the corner of the eye and corner of the mouth, as well as jumping up to the lacrimal, and for the V3 component from the submandibular below the corner of the mouth. The only other one is the otic, which is supplying and distributing on V3 towards the parotid gland. I like to have a pattern to remember the trigeminal nerve since there are so many branches. For the 3 major components, I like to think of V1 as being the sensory component, which is as easy as 1, 2, 3. The V2, which is also sensory, has 4 biggies for its distribution area, and V3 has both sensory and motor, and the magic number 12 is how I remember it, which is 4 times 3. Where does this come from? Is that I have 4 branches that are sensory, 4 branches that are motor to muscles of mastication, and 4 other branches. In the V1 distribution, remember this is easy as 1, 2, 3, NFL. And when you use this pattern, 1, 2, 3, NFL, you can see that there's lacrimal portion, which is part 1, and only has 1 branch. That's on the lateral aspect. The frontal branch, which has 2 components, the supraorbital and supratrochlear, and then finally the nasociliary branch, which has the ciliary branches, which are long and short, the ethmoidals, which are posterior and anterior, and then it will continue out as the infratrochlear. As far as the maxillary distribution, V2 has 4 biggies, 2 of which are nerves, the infraorbital and the zygomatic, which will carry out the communicating to the lacrimal gland itself, and then 2 areas. One is the nasal cavity, which will distribute to the mucous membranes of the nose, and then the mucous membranes that are associated with the palate. This is located by the pterygopalatine ganglia, which is located in the pterygopalatine fossa. An image showing some of the areas that would be relevant to cranial nerve 5, because the infratemporal fossa is going to be medial to the TMJ. And there you can see the condyle of the mandible and the TMJ. Here's the external auditory meatus, just posterior to that, and the chorda tympani is going to come out between the styloid and the mastoid process, which is going to be the facial nerve proper, and then chorda tympani is going to come through the petrotympanic fissure right in behind and running in a conjunction with the condyle of the mandible. Let's discuss the mandibular nerve, part 3. Remember, we said the magic number for this one was the cranial nerve, or the magic number 12. This means that there's going to be 4 sensory branches, 4 masticators, and 4 to other muscles. They can be divided up into an anterior and a posterior division, and what you want to remember about this is that the anterior division is all motor except 1 branch, and the posterior division is all sensory except for 1 branch. What are the 4 sensory branches? Well, I like to use the from ear to here memory tool, and I just make a C in front of my ear with my thumb and my index finger, and there's 4 nerves that run along that C. First, my temple, which is going to have my auriculotemporal. Remember, this is also carrying parasympathetic hitchhikers that will supply autonomics to the parotid gland. Then we have the jaw, which is our next thing that we hit along that C, and we have the infraalveolar going into the mandibular canal. Finally, we have the lingual, which will go to the anterior 2/3 of the tongue, and then the branch that will go to the buccal. I oftentimes will call this the buccal branch of 5 at this point, because it used to be called long buccal, but because there was no short buccal, they've gotten rid of that terminology. You can see the branches that will go to all of the areas that we've discussed. We have 4 motor branches to masticators, and we have 4 branches to other muscles. I've kind of highlighted those for you when you can see the muscles affected. Notice that we've got the masseteric muscle getting the nerve to masseter. We have the temporalis muscle getting posterior and anterior deep temporal. We have the lateral pterygoid and medial pterygoid getting branches off of the pterygoid divisions. In green, we have the mylohyoid and the anterior belly digastric, which are supplied by the nerve to mylohyoid. In this MRI, T1 weighted, you can see the inferior concha from the nasal cavity, and then you can see the lateral pterygoid with its fiber direction running back towards the temporal condyle. A couple more labels in here, and one more. If we go a little bit lower, we can now see the mandibular teeth and the tongue in position, and now you can see that rather large parotid gland and some of the vasculature that's heading through it. There's the vertebral artery coming up through the foramina transversaria, and you can see the dens, and finally you can see the spinal cord.